Adrenal insufficiency is a disorder of deficient cortisol production, with primary forms also involving aldosterone deficiency and secondary forms due to hypothalamic pituitary axis failure. Epidemiologically, permanent adrenal insufficiency affects about 5 in 10 people, with secondary causes being more common than primary disease. Iatrogenic adrenal suppression from chronic glucocorticoid use affects up to 0.5 to 2% of the population, making it a major clinical cause. Primary adrenal insufficiency is most commonly autoimmune, either isolated or part of autoimmune polyglandular syndromes type 1 and type 2. APS1 is caused by AIRE gene mutation and presence with chronic candidiasis, hypoparathyroidism, and multiple autoimmune endocrine failures. APS2 is polygenic and associated with HL-adoctor3 and CTLA4 variants, commonly presenting with thyroid disease, type 1 diabetes, and adrenal failure. Other causes of primary adrenal failure include congenital enzymatic defects, X-linked adrenal leukodystrophy, infections, hemorrhage, and adrenal infiltration. Secondary adrenal insufficiency results from pituitary or hypothalamic disease, including tumors, surgery, irradiation, Sheehan syndrome, or chronic steroid therapy. Clinically, primary adrenal insufficiency causes both glucocorticoid and mineralocorticoid deficiency, while secondary disease spares aldosterone. Primary disease is characterized by hyperpigmentation, hyponatremia in about 80%, and hyperkalemia in about 40% of patients. Secondary adrenal insufficiency typically presents with pale alabaster skin, fatigue, hypotension, and hypoglycemia without hyperkalemia. Acute adrenal crisis presents with shock, severe hypotension, abdominal pain, confusion, and can be life-threatening without immediate treatment. Diagnosis relies on ACTH stimulation testing, where a peak cortisol below 450 to 500 nanomoles per liter confirms adrenal insufficiency. Plasma ACTH is elevated in primary adrenal insufficiency and low in secondary forms, helping localize the level of defect. Plasma renin activity is increased in primary adrenal insufficiency due to mineralocorticoid deficiency and volume depletion. Acute adrenal crisis is treated immediately with intravenous hydrocortisone 100 mg bolus, followed by 200 mg over 24 hours. Aggressive intravenous saline at about 1 liter per hour is given initially to restore circulation and correct shock. Chronic replacement therapy uses hydrocortisone 15 to 25 mg per day in divided doses, with morning predominance to mimic physiology. Primary adrenal insufficiency also requires fludrocortisone 100 to 150 micrograms daily to replace aldosterone and maintain electrolyte balance. Stress dosing is essential, requiring double oral steroids in mild illness or intravenous hydrocortisone 100 mg bolus with 200 mg per day in major stress. The key clinical takeaway is early recognition and lifelong hormone replacement with appropriate stress dosing to prevent fatal adrenal crisis.